These are different types of interventions, and I'll go through them all one by one. So mechanical, there's the Mercy device. It's the first device that was approved, 2004. It's called the corkscrew, and I'll show you pictures of it, and you'll know why it's called the corkscrew. I personally dislike the device. It tears blood vessels. It just tears them up. And this was the #1 device used in one of the most recent trials that everybody's talking about in New England Journal of Medicine. Then you have the Penumbra device. I like this device. It's very good. It's been around since 2007. And basically, you take a catheter, you kiss the clot, and you use a little wire to break it up, and you suck it. You suck it all into this tube. You have mechanical disruption. That's what they did before even Mercy. They didn't have anything else. So they kind of went through the clot and try to, macerate it, basically. Then you have the retrievable stents, Solitaire and Trevo. I'll show you what their design looks like in a little video at the end. Basically, it's a stent, and it traps the clot, and then it pulls it back into the catheter. So the Proact Trial was the first trial ever done to prove that endovascular works. And they kind of randomized patients to a clot buster inside the brain through these small catheters versus nothing. And as you can see, recanalization, which means opening up the blood vessel, 66% of patients versus 18. So we know it works. It opens up blood vessels. Does that correlate to good outcomes? Well, in this trial, it did. At 3 months, he had favorable outcome of 40% compared to 25. And you might say that's a little lower than all the recent trials. Remember, these are the patients who have a big, thick clot. We're not looking at the small, little stroke. We're looking only at the big, serious strokes that are most likely life-threatening. There were a couple of other trials done, one with the Mercy device, the corkscrew device. As you can see, it only opened up blood vessels 48% of the time. And then it causes an 8% rate of hemorrhage. So we're not really opening that many more blood vessels, but remember, these are sicker patients. It's not the small strokes we're looking at. But their mortality was almost 39%. Now, Penumbra comes along and says they open up 80% of blood vessels, but they caused 11% hemorrhages. So they're causing a few more bleeds, but they're opening up twice as many blood vessels. Their good outcomes are not significantly better than doing nothing. Very sick patients, poor patient selection. Their mortality, though, is better than Mercy. It's 32%. But still pretty high. 32% sounds pretty bad to me. So then the group at University of Cincinnati came up with this IMS trial. They said, okay, we want to know if endovascular works for the 0 to 3 hours. We know it works for the extended time window. If the patient can't get IV TPA, well, it's either nothing or endovascular. Yeah, endovascular works. What about within the 3 hours? So they randomized these patients. They had pretty good recanalization, low rate of hemorrhage, and they only had 16% 90-day mortality. But all they were doing is giving IA TPA. So they just take the tube up there, squirt a little clot buster, and that's it. They don't break it up, they don't suck it out, they don't do anything else. And that's why they only open up 67% of blood vessels. So then the IMS-3 came out. This was supposed to be the end-all, the answer to everything. Phase 3, NIH grant, huge multi-million-dollar trial done across the country. And they were going to combine IV, a partial dose of IV, and then finish the dose with intraarterial, inside the blood vessel. And then versus IV TPA alone. Had to be within 3 hours. And the primary outcome was the same as all the other trials. They used the same definition. The trial was prematurely terminated, past the point of significance, so there's no point in dumping another $20 million in a trial. That's not going to prove anything. Here's the problem with the trial. So the endovascular, EST is the endovascular stroke treatment. They used IA TPA for the majority of cases. They had a total of 434 patients in the endovascular arm. IA TPA only was in 151. It was the majority of cases. Microsonic was this microcatheter was developed that they pulled off the market because they actually found out it caused bleeds. It actually didn't help a single patient, so they stopped it. It's unfortunate for the 14, but at least they didn't keep on going. 20% had no lesion to treat. They were still randomized to this arm, but they had nothing to treat. So you can see already some of the problems with this trial. Then we had 18% of the total endovascular patients were Mercy. Remember, Mercy is the device we don't like. It's the corkscrew. It tears blood vessels. It works sometimes, but it has a lot more complication rate. A lot more complications. Penumbra was only used in 10% of the trial. So Penumbra came out in 2007. They didn't approve it into the trial until 2011. So this is another drawback and a major criticism of this trial. 2012, Solitaire was approved. It was approved, I think, May or June 2012. We had it here, my second week here, we were using it already. Only 1% of the trial had those patients. And that's, as you'll see in the next trial, it's basically considered the cream of the crop, the best device out there, because it really opens up blood vessels and causes the least damage. The other big problem with the trial was IV TPA was the set piece in the control arm. Everybody got IV TPA. In the endovascular arm, you could get IA TPA, you could get this microsonic thing that would basically cause you to have a bleed and kill you. You could get Mercy, you could get Penumbra. Basically, there are too many options. So some of the learning points when they discussed this trial in the stroke conference this past February, the key messages, I'm not going to go through all the details, but basically early time to treatment is the key. The faster patients get to the emergency room, faster they get treated, the better they do. By giving a patient a partial dose of IV TPA and then trying to finish it 2 or 3 hours later in the cath lab doesn't make sense. Give him the full dose. And that's actually one of the main reasons, University of Minnesota, we never enrolled in this trial, because it didn't make sense. FDA is a proven drug. IV TPA is an FDA proven drug. Why would I give a partial dose of that and then try to prove something that we know might or might not work? So we always give full dose IV and then took the patient to the cath lab. Mercy has more associated complications. I respect everybody in this room, so I'm not going to say a curse word, but it's obviously. Majority of endovascular at large centers doesn't include these patients within 0 to 3 hours, because they get IV TPA already, and most of them do better with it. So why take them to the cath lab? Most of the patients that actually get endovascular treatment are posterior circulations. You have a little artery called the basilar artery in the back of the head that supplies the brainstem. Basic brain functions, breathing, opening your eyes. If that clots off, you're dead. I mean, you don't even, it's not that you're disabled, you're dead. You don't even live. So those are the patients that we treat. We treat the patients that have, they're on Coumadin and their INR is too high, so they can't get IV TPA. Well, we can treat those patients with endovascular. If you had any previous intracranial pathology, which means intracranial tumor, if you had a previous bleed in your head, you're never going to get IV TPA. You can still get endovascular treatment. And then there's obviously the outside the time window, my favorite population in the valley. They don't know what time the stroke happened. They woke up with it. They were last seen normal 8 a.m. Their husband, daughter, son comes in at 4 p.m. and sees them on the floor. So with image-guided therapy, we can choose the correct patient and we still treat those patients. And that's the majority of patients we actually treat here in the valley. This is very busy. I'm not going to go through it all. Basically, it's a comparison of the early cardiac trials and the early IV TPA trials. All the early IV TPA trials were negative. All the early cardiac trials were negative. It wasn't until we pooled all the analysis of all the heart trials that we proved that taking a balloon inside a blood vessel actually works. Before that, the IV treatment was just as good. That's the same thing here. This is still the first NIH-funded national trial, very early stage, using primitive devices. We already know that there are much better devices out there. The time delay was enormous. And this is, I'm just going to read the last quote because the PI of the trial, principal investigator, was just constantly said this throughout the stroke conference. Whenever a cardiologist asks me why all the trials that were published in New England Journal of Medicine last week were negative, my answer is imagine a coronary trial against IV lytics in which the door to balloon is 3 hours. And then you'll understand the trial results. And basically the meaning of that is current door to balloon time in the United States has to be 90 minutes. Medicare won't pay you if you don't open the blood vessel in 90 minutes. So why are we allowing twice as long for strokes? And that's something, obviously, there's a lot of universities and a lot of people working on it. So the SWIFT trial was the first trial to compare two devices. It compared the Solitaire device, which I'll show you pictures of later, and the Mercy device. Basically, if you see here, they created the hardest definition to prove. They said, not only are we going to open up blood vessels, we're going to guarantee there's no blood. So they said they had 61% of their patients open up and not have bleeding. versus 24% in Mercy. I told you, tears up blood vessels. So even if it opened up the blood vessel, it's going to tear. Symptomatic hemorrhage. Patient doing worse, patient who has a bleed and does worse, 2%. That's better than IV TPA. 11% in Mercy, which matches the Mercy trial. So it's not like that, people purposely tried to hurt the device. Their own trial showed 11%. 90-day modified Rankin of 0 to 2. Fully independent patient. No disability whatsoever. 58%. By far the best number of any stroke trial ever. Versus 33% for the Mercy device. So as you can see, every generation of devices or treatment paradigm, we're improving the outcomes. And that's why it's very interesting to be in this field. It's cutting edge. 90-day mortality, again, significant decrease. 17% with the solitaire stent device versus 38% in the Mercy. So less bleeds, less deaths, more patients going home and playing golf. What else do you want? We finally have a device that's a game changer. There was a Trevo trial that was also done, comparing Trevo to Mercy, and again, less bleeds, more blood vessels opening, and better, more improved outcomes. Another device that's a game changer. So everybody's asking, well, we have these confusing trial results, what do we do? And the thing is, we need a trial that compares the best devices, Penumbra or Solitaire, to IV TPA. And Swift Prime is actually going on right now, and hopefully we're going to be one of the sites. The other thing we need is, people are saying, well, endovascular doesn't work for, how do you know if it doesn't work for 0 to 3 hours, how do you know it works for after that? The problem is they've been trying to design this trial ever since the Proact Trial showed you back in 1996. The problem is there isn't a single doctor who would enroll the patient. If I told you your patient comes in at 6 hours, you're going to do nothing, or you're going to take him to the cath lab and pull the clot out. Are you going to do nothing? They really cannot find a single doctor who wants to enroll a patient in this trial. And that's why it's probably never going to happen. So the paradigm we have here is basically if someone comes in within the IV TPA time window, 0 to 4.5 hours, the top set of boxes, they're always going to get IV TPA. That's the standard of care. It's FDA approved. Now, if they have a severe stroke, they'll also get endovascular. If they wake up with a stroke, if it's an unknown onset time, if they have IV TPA exclusion criteria, they're on Coumadin, which a lot of people are on Coumadin on these days. They're on some sort of blood thinner. They had a brain tumor before. They had some brain surgery before. Those patients, we still have that option for them, and they go straight to the cath lab. This is the transfer guide. It's very busy. It's basically how all the hospitals in the Valley, so if you have a stroke or any of your family members have a stroke, you tell them you want to go to Valley Baptist. In Harlingen. Well, if you go to Brownsville too, it's a primary stroke center, and it's a very good hospital. So they'll be able to give you the IV TPA, and if you need endovascular, they'll ship you over. Dr. Gaetan's a great man. He does a very good job over there. So this is one of the cases. I want to show you some pictures now. We're done with the slides and the words and numbers. Basically, the whole top of the head should have blood vessels, and it doesn't. It's completely clotted off, basically behind the eye. This patient's not moving, not talking, not doing anything. We take our little tube, our microcatheter, and we go past the clot, and we inject to make sure that we're past the clot. And then we take the corkscrew. This is one of the devices we used to use. We don't use it anymore. And this is what it looks like under X-ray. And basically, you release it, and it kind of just makes this corkscrew shape inside your blood vessel, and then you're supposed to drag it. And in this case, it opened up the blood vessel. It works sometimes. And it opened up this blood vessel. That's a picture of the clot. It's actually pretty big. This clot would have never opened up with IV TPA. Now this is the Penumbra system. It's much sexier. It's very sleek, and I have a nice video of it. And basically, that tube is connected to a suction device. And the suction device has this, we call it a separator, that goes through it. And what it does is it goes through the clot, and it's breaking it up. Every time it goes through, it breaks it up, but it's under constant aspiration. So anything we break, it doesn't go distal. It actually comes right into the tube.